So good afternoon, everybody. Thank you guys so much for joining us for this day 3 of our 4th annual Inclusive Excellence Week here at the School of Dentistry. It is a privilege to have one of my colleagues and friends join us today, particularly around the notion and topic of disability justice and our ethical commitments around that. Although I think in dentistry, we are doing a better job of having conversations around diversity and inclusion. One of our areas of opportunity remains to be how we interact and care for those patients, colleagues that may be differently bodied able, right? And then the various nuances around neurodiversity and the diversity spectrum and conversation. So we have with us today Nanette Elster, who is an associate professor at Loyola University, Chicago, where she's an active educator in various graduate programs, teaching a variety of courses related to law, pediatrics, oral health, genetics, and professionalism. She also supervises the graduate program's writing courses, master's capstone course, and doctoral capstone courses. She has extensive experience in legal, public health, and ethical issues related to women's and children's health. She has spoken nationally and internationally, is an author of numerous articles on the legal, health policy, and ethical implications of a range of public health issues. She's appeared on various media staples such as CNN, Good Morning America, The Today Show, NPR, the list goes on and on and on. She has served for many years as the manager of ethics outreach for the Council on Ethics, Bylaws, and Judicial Affairs within the American Dental Association, and she is the director of communications for the American College of Dentists and serves as the editor for the Journal of the American College of Dentists. And I am really excited to call her a friend in this work around diversity, equity, and inclusion, particularly in our political state these days. Friends in this work are few and far between. And so I appreciate that Nanette is a wonderful colleague and a friend. We have about 35 or so students in the room, faculty and staff joining us. And then we have folks via Zoom as well, Nanette. So It's just my honor to introduce everyone to Professor Nanette Elster, and she'll take it away.
Wow, Carlos, thank you so much. I hope I can live up to all that. And I am thrilled to be here and so grateful to Carlos for inviting me to join you today. He's right. Finding folks who are aligned and friends in this field is so incredibly important and energizing. So I hope today what we're going to talk about will energize you. And as Carlos mentioned, we are seeing progress. We are absolutely seeing progress. But I do think in our world of inclusion and diversity, the voice of the disability community, because it in and of itself is so diverse, is one that has not quite captured as much attention. And so I hope today we'll have a chance to talk about some of that. I'm going to focus on a few key areas. As I was preparing for today, I thought, oh my goodness, I could do this for days. So you're getting my thumbnail sketch with just a few focal points. Happy to talk more. My contact information will be at the end. And I hope anyone with further interests will definitely reach out. So let's get started. And of course, as we do this, my slides, there we go. All right, disclosures. I am the content director for the American College of Dentists and an associate professor at Loyola University, as you know. My views are my own, and that's really important to discuss here. They are not those of the organizations that I am affiliated with. My other important disclosure is that I am both a parent and a step-parent of adult children with disabilities. I have a stepson who is autistic and goes to a therapeutic day school. I also have a daughter who is autistic. My stepson was diagnosed when he was 3. My daughter was diagnosed at 18. My daughter is at an Ivy League university, nonetheless, still disabled. She also has a physical disability and suffers from an autoimmune condition. So these issues are really very much near and dear to me, and I have had permission to disclose that, by the way. So I want to talk about my learning objectives here today. And one is just to talk about disability as an umbrella term. The other is that when you leave here, you'll be able to sort of compare the legal and ethical and professionalism obligations around this issue. And then finally, I hope you'll be able to distinguish between the various levels of advocacy from the individual microcosmic patient level all the way through the macrocosmic global level. So obviously we can't get into all the nitty-gritty details, but certainly we'll touch on a lot of that. So to start, I want to talk about how broad disability may be. It can be physical. Certainly when we look at images of disability online, you pull up disability in an image and it's always a wheelchair for some reason. But those physical disabilities are far beyond the inability to walk. They can involve any sort of physical aspect. They may be cognitive, they may be psychological, they can be invisible. They can also be very visible. They can be acquired. They might be congenital, they might be hereditary, or they could be a combination of any one of these. And so we can't lump it all together and think that this is some sort of monolith. Disability, various shapes and sizes. And if you think about it, at some point in all of our lives, we may experience disability. I think the one point I left off here was it was getting too small. It could be permanent or temporary. Any of you who've broken a bone, that could be a temporary disability. I'm just recovering from COVID. Those 10 days, I was not functioning at a level that I normally would. And as we age, we might also see other things that might fall into that category. This is important because according to the Centers for Disease Control, about 1 in 4, 27% of adults in the United States have some type of disability. And again, because these may be invisible, you may not know. And that's important too, particularly when dealing with patients, and we'll cover a little bit of that. And I just want to give you a few more statistics. I know this is a really, really busy slide. But about 1 billion people worldwide have disabilities. 61 million in the US have an intellectual or physical disability. That 1 in 54 number changes almost annually, I would say. We're now at 1 in 36 children are diagnosed with autism. That doesn't even count the number of adults who are diagnosed with autism. So that's a huge, huge number. And about 1 in 700 babies are born with Down syndrome. So these are big and important numbers to be paying attention to. The number one health need for people with disabilities is adequate oral health. So about 6.5 million people with disabilities are not able to access the oral health care they need. I say all this to kind of frame the problem that we're trying to address here. So these individuals could have higher rates and increased severity of periodontal disease, higher rates of untreated dental caries, more missing and decaying teeth, and in turn, more problems with heart disease, diabetes, all of this being interrelated. Not to mention there may be other issues, mental health issues that relate to all of these aspects as well. So as we have this discussion, I thought it was important to talk about the language we use because language really, really matters. Are we talking about a disease, which according to Prabo is an abnormal condition affecting the body? Are we talking about a disorder? This could be a functional abnormality or a disturbance. Both of these are medical definitions and pretty important. Or are we talking about a disability? Which, as you can see here, might incorporate these, any condition of the body or mind that makes it more difficult for the person with the condition to do certain activities. So this is a legal definition, and this does become very important, but it kind of combines both disease and disorder. And then we have a new term, relatively new term, and that's a difference, which might also include any one of these. If we think, for example, about deafness, for some, deaf is a culture, not a disability, not a disorder, but just a difference. In the neurodiverse community, we see that same terminology used. It's a different way of thinking. It's a different way that the brain functions. And so it's important that we think about how we use these terms, and that's more of a social construction. But using them interchangeably might be problematic because we do have certain rights and obligations that are dependent upon the language used. This is why the language matters. How we use the term determines what sort of accommodations, supports, services, etc. are required or available. And it also matters who must or should provide them and in what setting that is required. So I wear my hat as a lawyer, an ethicist, and a public health professional as I talk about these issues. Sometimes very hard for me to take those hats off and put one on over the other. So today I'm going to try to distinguish each of those areas, and hopefully we'll get at why this is so important in dental practice. So the legal requirements are actually very dependent upon language, and the term disability is the one that is used in the legal arena. On the left, with my very sketchy outline here, you'll see that these are laws at the federal level that impact disability rights and get at things like discrimination, access to care. The one that you've probably heard the most about and gets the most confusion among dentists is the ADA, Americans with Disabilities Act, not the American Dental Association. And this one really covers any place of public accommodation. And it's not just applying to people who have a disability, but people who might be perceived as having a disability as well. Public accommodation is a broadly used term, but would cover a dental office, for example. Other of these that might be impacted would be the Civil Rights of Institutionalized Persons Act, Individuals with Disabilities Education Act, things like requirements for certain therapies that might involve oral health professionals that could be included here as well. The thing that's important about these legal requirements, and as I said, these are at the federal level, this is just the floor. This is not the ceiling. So each state might have their own laws about disability rights, which may be even more expansive, apply to more individuals, and require certainly more accommodations to be made. So it's not only important to familiarize yourself with what the federal law says, not only know about the Americans with Disabilities Act, but to know about your state's laws. So for example, in our state in Illinois, we have the Genetic Information Privacy Act, or related to the Genetic Information Non-Discrimination Act. That's at the federal level. Illinois state law came first. It allows someone to control the disclosure of their information. It prevents against discrimination in insurance, employment. California has their own version of that prevents discrimination in employment, insurance, mortgages, life insurance, disability insurance. All this relates because sometimes, for example, genetic conditions could be disabilities or the appearance of a disability. So I use that just as one example. There are also other obligatory standards. So particular to dental students and dental education, CODA, Section 2.25, graduates need to be competent in assessing and managing the treatment of patients with special needs. Being able to make referrals, knowing about communication techniques, these are all integral to the education. But as we know from research that's been done, still a number of students, once they're practicing dentists, don't feel comfortable enough. And so thinking about what more can or should be done, and that's hard because we know the curriculum already covers so much, and the time to fit those things into what's already happening from an experiential standpoint as well as a didactic standpoint can be really, really difficult. Nonetheless, it's important. But again, shifting the lawyer hat off for a minute here, ethics and law are not the same. And this is also probably the gist of what I want to focus on today, is that we're here today talking more about ethics and professionalism and those obligations. So what I would say is, and this is one of my favorite definitions, it's a thinker's guide to ethical reasoning. It's a very small little book, almost like a pamphlet, and that I read because my daughter was reading it for some class in high school. And it was sitting on the dining room table one day. I picked it up because I have a real interest in ethics. And this definition stood out to me. It says, what is illegal may or may not be a matter of ethics. And what is ethically obligatory may be illegal. What is unethical may be legal. And sometimes, as healthcare practitioners, being faced with that distinction is really important. And at the individual level, it may require you, the clinician, to make a decision which consequences you're willing to bear, the consequences of ethics violations or the consequences of a legal violation. Both are pretty heady and are important to think about, but sometimes we need to make those choices, and hopefully never in a vacuum, but with the support of colleagues and our institutions, sometimes making those decisions can be a little bit easier. Another definition I love is that by former Supreme Court Justice Potter Stewart, who said ethics is knowing the difference between what you have a right to do and what is right to do. And our focus today is going to be on what is right to do. Even the American Dental Association Code of Ethics and Professionalism recognizes this, says that although ethics and law are closely related, they're not the same. Ethical obligations may and often do exceed legal duties. This is part and parcel of almost any profession. It's part of our professional identity formation, who we are as professionals, making those tough choices, but being equipped to make those difficult choices. So here, this is what all patients should expect and what dentists are professionally and obligated to do. Each of these is kind of embedded within the ADA code. I put advocacy at the top here, and that's going to be a big focal point of what I want to share with you today. And I want to focus here because advocacy can be a way to promote or secure all of these other elements, patient well-being, choice of what's available to a patient, protection from harm, as well as justice, social justice, retributive justice, restorative justice, justice in all of its differences, but primarily focused on fairness, fairness and equity. So you're probably all familiar with this already, and I'm just going to do a really brief overview, but I want to relate it particularly to the issue we're talking about today, disability, special health care needs, the principles of autonomy, non-maleficence, justice, beneficence, and veracity. So autonomy is about self-determination, and it's about the ability to say yes or no, for example. But that can only happen with enough information to make an informed choice. And I put here a whole lot of things here: shared or supported decision-making / informed consent. This is particularly important when we're dealing with patients who have disabilities, again, depending on if it's an intellectual disability, if it's a physical disability. It may just be one's unable to speak, for example, a physical disability. That's often interpreted, however, as an intellectual disability. So even if someone may be speaking on that person's behalf, using their words, it's still up to the patient to exercise their autonomy. And maybe they've got autonomy that's waxing and waning. Maybe you're treating a patient with dementia, for example. And so in some moments, they may have capacity. And for some decisions, they may have capacity. Do I want fluoride treatment? Yes. Do I want a restoration or an extraction? Maybe that isn't as easy a decision. So this is where shared or supported decision-making can be important. It's important to know in your state if shared decision-making or if supported decision-making is legally recognized. That's where the person, again, may not have the capacity to make all decisions, but with a supportive individual, whomever they designate, they could make that decision to the level in which they're able. So thinking about who's making the decision. Is it a parent? Is it a patient? Is it someone else? Is it a state-appointed guardian, for example? What are the goals and values of the patient? Not of the decision maker, but of the patient if the patient's not the one making the decision. And then what is not only the patient's understanding, but if there is another decision maker, what's their understanding of what's happening? And if someone other than the patient is making the choice, is that decision maker making the decision that's in the best interest of the patient? Or might they have competing interests where their own interests might prevail? So that's important to look at too. And then involving the patient and or the decision maker as much as possible in treatment decisions every step of the way. So informed consent isn't, or shared decision making doesn't just happen in one moment in time, but needs to happen throughout the entire process. Then there's issues related to confidentiality, access to records. I want to highlight access to records too when we talk about patients with disabilities, because many of them have complex healthcare needs and their records are important to share, and it must be easily accessible to them to share with other healthcare providers because often their care is interrelated. And unfortunately, in some instances, particularly with adults, even with complex health needs, those aren't as coordinated as we might see with pediatric patients. And the electronic health record is often not integrated between oral health providers and other primary care providers. Non-maleficence, also key here. It's about avoiding harm, acting within the bounds of clinical care, not abandoning patients. So their needs may become more complex. Not about abandoning them, but maybe making a referral when it's in the patient's best interest. Maintaining your skills and knowledge. Sometimes that might mean acquiring skills and knowledge. Maybe you had a patient for many years who's acquired a disability. So it might be about getting up to speed with what needs to happen. Properly overseeing auxiliaries who might be treating patients, making sure they understand necessary communication, are treating patients who have special health care needs with respect and dignity, and all of those elements that are critical. And I mentioned here just not treating patients when ill or under the influence of medication or substances. This could be a really critical point. It seems small, but what if you're treating a patient, for example, who has an autoimmune condition, may be immunocompromised? If you're treating them, you're cold, you might feel like you can work, and that's great. But your cold for them could be something so much more and could be life impacting. So it's important to think about that. And while I'm on this point, clinicians themselves might have disabilities. That's a whole separate talk, but I don't want to ignore the fact that when we talk about disability, it's not just about the patients, it's about providers as well. And so there are elements that might be overlapping when we think about that element. Then there's beneficence, doing good. Course, providing care is doing good. So that one seems pretty straightforward. It applies not just to the patient, but to the public you serve. There's a social contract between dentists and the community. And so being acting in good faith, doing good, not just for the individual patient, but for the community, the public. When possible, providing charitable care. It's important to recognize that's not always possible. There are a lot of expenses involved in running and managing a practice and providing dental care, but refusing care because it might require more time, more staffing, those could be problematic. And so when possible, finding ways to do that, finding resources within your community, sharing those resources can be helpful in being able to move forward in that regard. Providing, again, appropriate oversight of team members, and then working toward improving one's community. And again, I raise that because at some point, everyone might have some sort of disability, be it temporary or permanent. And so working within the community and being a part of the community that can be dependable in this regard is critical. And then justice. So not refusing care based on race, gender, national origin, religion, ability, or other protected category. This mirrors law but this is an ethical obligation. The ADA back in 2018 actually added the category of disability here to ensure that those with disabilities were treated appropriately. It's about being fair to patients, colleagues, and staff. Maintaining a respectful and collegial work environment, that's important, not just for everybody working there, but for everybody who's encountered in the office. So again, making sure that those patients who come in with disabilities are not stigmatized, are feeling comfortable, that they're treated with respect and dignity, communicated to in a way in which they're comfortable communicating. That might sometimes mean a sign language interpreter, or it might mean if you have someone who has a hearing difficulty, writing things down and going back and forth with that written word. Advocacy. So you see here, this is an ethical obligation, and that's why I wanted to focus some time here. If discontinuing care, doing so with notice and an opportunity to secure another provider. This might be particularly difficult when you're dealing with patients who have special health care needs. You might have developed a rapport, and helping them find another provider. The time it might take them to find another provider could be extended beyond your patient who may not have the same special health care needs. And then veracity. This is about the concept of professionals having a duty to be honest and trustworthy in their dealings with people, not taking advantage, for example, not recommending more care or a lesser standard of care because a patient may suffer from a disability. Under this principle, the dentist's primary obligation is to respect the position of trust that's inherent in the dentist-patient relationship and communicating truthfully while maintaining intellectual integrity. So as you can see, all of these principles apply, and they're really relevant when we're dealing with patients with disabilities, because those patients face an inordinate amount of barriers. These are not all of them, but certainly it's an important starting point. First one I put here is that dentists who are or underprepared and or unwilling to treat. That CODIS standard is relatively new. So while students coming out of dental school may have some of this preparation and understanding, many practitioners who came about long before the CODIS standard may feel uncomfortable and feel unprepared in how to treat patients with special healthcare needs. Their offices may not be equipped. So that talks about the lack of physical access. This is not just about in getting to the dental office, but it's about being able to sit in the dental chair, room to move around in the office. Physical access may also include having to go more than one place. So maybe you can't treat them in their office, they've got to go somewhere else, and they're moving back and forth between that. There may be low health literacy, not just of the patient, but of someone who might be making decisions for them. There may be communication obstacles. Patient may be nonverbal. Patient might be hearing impaired, sight impaired. There may be just language barriers with regard to the spoken, what language they speak. And again, there's often a perception that if one's nonverbal, that they also suffer from an intellectual disability, and that is not always the case. They may have an assistive communication device, which again, that may pose some difficulties in utilizing that and how that translates in the office and in the care being provided. So if someone's laying back in a chair and they're using their assistive communication device, it may be hard to work on their mouth because they've got to look at their device to be able to communicate with you. Cost and reimbursement is a huge problem because they're already extensive costs for patients with disabilities. Many of them are covered by Medicare or Medicaid, which can be problematic. Many of them have insurance caps, which could be problematic as well. And again, some have no insurance but for Medicare or Medicaid. A lot of these patients have a past experience, which is negative. And so being able to provide trauma-informed care is essential in this context. Individuals with disabilities are at suffer much higher rates of abuse in many contexts than other patients. So being aware of that and being sensitive to that and having the ability to address certain traumas when dealing with patients, particularly those who can't communicate for themselves, can be really important. And then bias. There's a lot of conscious and unconscious bias. There's bias around assessing the quality of life for someone, but they might not care about what they look like because, why would they? Or that, again, that bias I mentioned, if someone can't speak, that means they don't understand what's happening. So we've got to keep those biases in check. And one way to do that is by just becoming more informed, more exposure, more information, asking the patient what's important to them, asking their decision maker, if one accompanies them, what might be important in the context of working with that particular patient. So I just wanted to give some examples here why this is important, these barriers, because discrimination is actually a very real issue for those who are in households experiencing disability. So a greater proportion of individuals in households experiencing disability, 52.8%, report having had experiences of discrimination in a healthcare or oral health care setting. That goes to that idea of trauma-informed care, overcoming bias. So this is real. This isn't just a perceived notion. This is something that actually does exist. But it's not all negative, because I think barriers present opportunities. And this is one of the things I love about working with Carlos, because he too sees any barriers an opportunity. It's an open door for us to expand our minds, to expand what we do, and to grow as professionals. So certainly changes in the dental school curriculum can be critical, and we've seen that happen with the CODA standard. Interprofessional education as well as interprofessional practice, really relevant. And I just want to share one brief example of something we're doing at Loyola. We had some students, our medical students, who were really interested in this idea of being better equipped to work with patients who suffer from intellectual and developmental disabilities. So they put together an elective for second years, and they've opened it up a little bit. And at my prompting, they're going to be opening it up to our dental residents as well. And what they are doing is that, as I said, it's called the Disability Healthcare Elective. A student who started this is a young woman by the name of Emily Carnes, with some of her other classmates, began this. They created it as a way of, and I'm going to quote from Emily here, improving competency and confidence in caring for individuals with intellectual and developmental disabilities through community involvement in curricular change. So they're bringing in community members. They're working with them. Some of them are willing to be standardized patients. They're having a mock interview, for example, so they get comfortable in the clinical setting, the individual with an intellectual and developmental disability, and the students are getting comfortable. Simple things like taking a history, communicating with one another, taking some of the mystery out of it, so that when there is an acute situation, an emergency, both are feeling more comfortable. The patient with their clinical care provider, and the clinical care provider with the patient. How to communicate, how to balance this. What might be some of the individualized special needs that patient has, or patients who may suffer from a particular type of disability may have. So for example, those with neurodiversity may have sensory issues, could be sight, could be sound, and being able to deal with that. A headset, for example, to block, noise canceling headset could be incredibly helpful. Dimming lights if possible. Those are all ways to make someone feel more comfortable. Advocacy is another opportunity, and then some combination of all of these. So I say this is about advocating for social justice. I want to talk about what it is, who's doing what, and for whom it's being done, why, and how. So advocacy in the medical profession, and I include dentistry here, includes activities related to ensuring access to care, navigating the system, mobilizing resources, addressing health inequities, influencing health policy, and creating system change. That's health advocacy. This is from Nanette et al. In 2017. And you can see that all of those elements I mentioned before, all that's incorporated in the ADA code, this is part and parcel of the ethical and professional responsibility of dentists. So advocacy and social justice do go hand in hand. So James, writing Physicians as Advocates for Social Change, wrote that advocating for social change goes far beyond making charitable donations or going the extra mile for your patient. It's about advancing practices and policies that support health equity. I would diverge a little bit here to say that we shouldn't minimize making charitable donations and going the extra mile for a patient, because I think those are important and they're not mutually exclusive from these bigger pieces. And sometimes, maybe as a newly minted dentist, you can only do so much. You've got to be working to pay off your debt. You've got so many things that you're trying to deal with all at once. Maybe you've just bought into a practice and you have managerial things that you need to attend to. So doing what you can do, every little bit counts. I don't want to minimize any step in this advocacy process. So advocacy, a lot of people just think it's lobbying. It's going to, your state capital or Capitol Hill and, talking to legislators, but it is a lot more than that. It's not just lobbying. It's not just about educating legislators. And even educating legislators can happen in a lot of different ways. A letter writing campaign. You could develop a briefing book for a legislator and send it on to their aide who would share it with a legislator. So lots of ways to influence and educate legislators. It's about educating the public, because you might find advocates in the community around you who could take your message where it needs to go and expand upon your message. It's about doing research, clinical research, policy research, all are important. Sometimes even litigation is part of advocacy. Dealing with an insurance company for your patient on behalf of one individual patient, that's advocacy too. So as I mentioned, it is an ethical obligation and it's integral to professionalism. So I just wanted to share with you 3 different professions and their codes of ethics and what they say about it. So physicians, individually and collectively through their organization, should participate in the political process as advocates for patients or support those who do. So again, you can do it in a lot of ways to diminish financial obstacles to access to healthcare. The ADA code, the preamble, which really sets the stage for the whole code, important here. Qualities of honesty, compassion, kindness, integrity, fairness, and charity are part of the ethical education of a dentist and practice of dentistry. Each dentist should share in providing advocacy to and care of the underserved. So it's right there in the Code of Ethics. Social workers, too, should advocate for living conditions conducive to the fulfillment of basic human needs, promote social, economic, political, and cultural values, all for social justice. This applies across the board. And as we mentioned before, sometimes when we're talking about underserved communities, we overlook patients with disabilities. They are really a group that needs advocacy as much as any of those other groups that we talk about. They tend to be lower income. They tend to have lower education rates, poorer health needs. So really, they fit that umbrella of being underserved in many different ways and in many different levels in our communities. This is just a slide I wanted to share, and Carlos can share all these slides with you, but these are just some examples of interpersonal, communication skills, organizational, the organization you work for, change the mission, talk about the values, talk about the community you serve, the health system, how can we improve access, how can we improve quality, and then policy, talking about the affordability, inclusion, and exclusion. This is where that political action takes place. So you see, this can happen across many, many levels and layers. So how? Well, a starting point again is in dental school with advocacy, training, skills that need to be taught. A 2021 survey found that most U.S. medical schools offer at least one advocacy course, but the majority are elective rather than required, and the structure and content varies. So as does the sustainability of it. That's the medical arena. But dentistry, we also have some specifics here and why it's important for dentists in particular. Amini and colleagues wrote about this in an article published in 2021 in Frontiers in Oral Health. They said dentists are in a unique and privileged position to advance the oral health of populations through public policy and advocacy. Dentists' high level of specialized knowledge and credibility with policymakers makes their engagement critical for oral health advocacy. And I'd say aligning that interprofessional practice and education, working together with other professionals, one, lessens your burden, but two, increases their strength. So that is a great way to merge those things together. One example is an advocacy training. There's a curriculum for pediatric dental residency programs. Even though some is specific to pediatrics, a lot of this could be translated to apply to those working with patients with special health care needs. And in fact, for pediatric dentists, CODA does have two requirements that are relevant here. 428, which is a requirement for didactic instruction in advocacy, and then 429, which is a requirement for experience in advocacy. So that is something that could be translatable, even though not a CODA requirement, could be something worth considering kind of more globally in the education process. So I want to summarize, and I know we're almost out of time. I want to see if we have time for a question or two. But in summary, only about 20% of variation in health outcomes can actually be attributed to direct critical care. It's through advocacy that clinicians can influence the other 80%. Things like socioeconomic and environmental conditions that result from policies and programs that affect health in your community. Things like clean water, air, access to needed health care, and affordable housing. This all works together. Even fluoridation, another issue. Safe drinking water, important. And of course, I wouldn't be really doing my job if I didn't end here with this ever important and relevant quote from the former Surgeon General, that you cannot be healthy without oral health. So we don't want to further disadvantage those with disabilities. So it really is critical to providing healthcare services and advocating for improvements and access to care for those with disabilities. So I'm going to end here and stop sharing. That's my email if anybody has any further questions, but I'm hoping there might be some time for a question or two. And if I can't hear you, I'm sure that Carlos could just shout it out, or those of you that are via Zoom, feel free to unmute and ask away.
Thank you so much, Professor Elster. We really appreciate it. Any questions in the room at all? And topics that were broached? Yes.
Would it be considered, can you hear me by the way? Sorry. I just tell you the question.
Yeah, I'll repeat it.
Yeah, perfect. So my question is, in regards to the limitations, would it be considered you decide halfway through your procedure that you don't have the wherewithal to finish treatment of your, for example, let's say cognitive patient.
So his question is in reference to maleficence specifically. Say you are treating a patient and realize maybe halfway through the procedure that for some reason you feel like you need to stop the procedure based on either you or the patient's doing. Is that considered maleficence? Is that the question?
Yeah.
Okay.
So again, we're going to try to minimize harm. You can't always avoid harm. Things happen, but this is why it's really important to have that information period at the beginning, the informed consent process, the shared decision-making or supported decision-making. It's about doing a good assessment at the outset, so you might be able to anticipate what lies ahead. If it is complex, if it is a patient with, and I'll use examples from my own experience with neurodiversity, for example. You know, if a patient with neurodiversity all of a sudden gets uncomfortable and starts moving around and can't you can't complete a procedure. It can happen. It's about stabilizing them, working with them or their decision maker, care provider to figure out what steps are next. Making sure that you can take those steps. Communication can be critical here.
Financial.
I'm sorry. Was
That's
there
okay,
another?
keep going.
So I wouldn't call that non-maleficence. There are ways to, again, you don't want to just engage with a patient who might have a special health care need without you being fully informed in advance. Is this an area you feel comfortable with? Do you need to make a referral? Do you need someone who's working with you alongside you to do this? Things like sometimes anesthesia is necessary. Avoiding restraints can be critical for both the purposes of providing trauma-informed care, as well as that may not be the solution. Holding the patient down to do what they need to do, even if they didn't have a trauma before, you may be creating one and impeding further treatment. So again, getting the information, feeling equipped to move forward is the best bet. And if you reach that circumstance where something does go wrong, getting help immediately, stabilizing the patient is going to be, and again, same with a patient who doesn't have a developmental disability or a physical disability.
I think we had one other question in the room and then we'll probably have to close.
Okay. For a patient that has someone speaking on their behalf, maybe there's a language barrier and you're speaking to the person, translating for them, and you are kind of unsure if that's what the patient actually wants at the time. How do you minimize that conflict between you and the person talking to say you are unsure if that's what the patient actually wants, or if this is something like, how do you read that without making too much conflict?
Yeah.
So a lot of times it's about having, and this is one of those access issues. It's about having a neutral translator. Often if you have a friend or a loved one or a family member doing the translation, you face that problem way more commonly. And that's not just with patients with disabilities. That's patients with language barriers because you don't speak the same language. When and if at all possible, again, having a neutral translator, there's a lot of translation services that are available. Again, a cost. This is important. It's a cost. There are some federal funds that cover that in some settings. Any of you who might work in a clinic setting within a hospital would have access to those translators. But that's one way, trying to see if there are visual aids that you can use in communicating with the patient. Other ways of describing that information so that you have a check and balance on that is also critical. So yeah, those are real issues that come up, but again, as you can see, not unique to the patient with a disability.
Well,
Can I add something
yeah.
to that? I'd like to add to that. If you feel like your patient isn't understanding you or you're not 100% sure, have them or their caretaker regurgitate it back to you in the way they understand it. Because if they tell you what they think is going to happen and it doesn't convey, then you can add that extra piece of information for them.
I agree with completely. Informed consent isn't just about throwing information at people. It's about them comprehending it. And it is an ongoing process. So not just saying it back, but asking follow-up questions, repeating it along the way, because we know dental procedures are procedures. It's not just one moment of doing something. It's stepwise. And at each step, making sure the patient's comfortable, making sure the patient understands. Also not speaking down to the patient, but you will get a sense of that rhythm and rapport that you need, and making sure, again, by asking those questions and having a dialogue. Informed consent needs to be a back and forth. It's not just you speaking at a patient. It's about them asking you questions. It's about you asking them questions and really getting at those goals and values and comprehension.
Awesome. Well, thank you so much for your time, Professor Elster. We really appreciate it. All of our students, faculty, and staff that showed up both in person and virtually, really appreciate you taking this time out and joining us this week. So thank you so much.
Thank you. This was great. Thanks for the questions. Be well.